Chapters also, a couple of chapters. So it's one topic, yeah, there's a couple of chapters. So Code of Kimball is the textbook I used for the basis for the skeleton of this topic. There's a chapter for acute kidney injury, there's a chapter for chronic kidney disease, and there's also a chapter for dialysis. Okay, so if you have questions, there's a lot of resources, there's a lot of pages there that you could look at to try to answer your questions. So before we get started with the material, any questions from you guys? Okay. All right, so the kidneys are an important organ. Does anyone want to offer to me a thing that the kidneys do? Why do we need kidneys?
Maintain electrolyte balance and pH.
Maintain electrolyte balance and pH. Beautiful. Anything else? Remove waste. Yeah. Good. Any others?
Regulate blood pressure.
They regulate blood pressure, right? They're obviously related to blood pressure, so all our medications, hypertension, a lot of kidney implications. Good, so that's pretty much exactly what I was looking for. So when you end up having kidneys that don't work, these things go wrong. So we look at it kind of in a couple of different, not silos, but we break it down to sort of conceptualize it more easily into the acute setting and to the chronic setting of dysfunction. So acute kidney injury is when you have an abrupt decrease to renal function in a short course, acute, right? So hours to days, the kidneys are not working so well. So it does exist. So what happens is exactly what you guys said, but broken, right? So you accumulate these wastes, nitrogenous wastes. That process is called azotemia. It's the medical term. You can't balance fluid, right? The kidneys get rid of fluid, obviously. We're all drinking our morning coffees, so very soon our kidneys will be getting rid of more fluid, right? Balance electrolytes, acid base. You said pH, which was great. So some terms that will come up in kidney injury are oliguria or anuria. Oligo means little or small. So this means a small amount of urine, less than 400 mLs per day urine output. And a or an means not, right, or none. So anuria means no urine, less than 50 mLs per day is what they'll consider the upper limit of anaerobic. Does anyone know what like a normal urine production is? Are we kidding? A liter is actually pretty close. Yeah. So if you were it's a weight-based number. The lowest amount of urine that you're usually going to produce on a daily basis is half a cc per kilogram per hour. And that'll come up later. Half a cc per kilogram per hour. So if I'm 80 kilos, that means I make 40 an hour. So if you multiply it by 24, you pretty much get a liter. So this contrasts with chronic kidney disease, which is a progressive deterioration of kidney function. This is irreversible damage to the nephrons, and this is something that occurs over months and doesn't go in reverse, okay? So this occurs across a continuum of stages or a spectrum. So you can have mild chronic kidney disease progressing to the worst kidney disease, which we call end-stage renal disease. End-stage renal disease is defined here. You can see less than 15 mLs per minute for 1.73 meters squared, or requiring chronic renal replacement therapy. So we're going to look at what this number means. But what does chronic renal replacement therapy, what does that mean to you guys?
Dialysis?
Dialysis. So chronic renal replacement therapy, it means you're doing something that replaces what the kidneys do, renal replacement therapy, and dialysis is the machine that allows us to do that. Some other terms that are good to know: proteinuria and microalbuminuria. This is the definitions for when there are different levels of protein in the urine over the course of the day. The numbers to remember are 30 to 300. Okay, so 300 is full-blown proteinuria, 30 to 300 is microalbuminuria, less than 30 is normal. So when the chronic kidney disease is at its last stage, end stage, you end up going to hemodialysis. This is what the machine removes excess water and toxins from your body, and we'll look at some more pictures, but essentially you have blood coming out of a vessel, going through a machine, and coming back into a vessel here. So it exchanges things at a semi-permeable membrane. But we'll look more at that near the end of class. So we're going to look at what's called the glomerular filtration rate. So this is a GFR. It's a standard abbreviation everybody should know. This is a number that is used to determine baseline kidney function and to monitor progression of kidney disease. And so we can quantify kidney function. You haven't learned all the D&Ds, obviously, but when you look at other organs' level of functioning, think like liver function, there's no way to quantify it, right? If you've been looking in like your package inserts and stuff like that, they don't say liver function 35% to give this dose. That doesn't happen. With the kidneys, we can do that. We quantify it. We give a number to how well the kidneys are performing, and one of the numbers is the GFR. So the glomerular filtration rate is the glomerular filtration rate. So this is a view of our nephron here. You have blood flowing into the glomerulus, and then flowing into little capillary beds, real tiny, and then they go out through another arteriole. So in through the afferent arteriole and out through the efferent arteriole. And when it's in this little capsule here, you end up making it filtrate. So some of the fluid is going to filter, and this eventually goes through your loop, collecting ducts, and out of the body. So the glomerular filtration rate tells you how well the glomerulus is filtering toxins and water. All right, so it kind of makes sense. So we can end up using an equation. The most common one is the MDRD equation, the modification of diet and renal disease, MDRD equation. And this is used to detect and stage the degree of CKD. Does that sound familiar to you guys? Have you heard MDRD before? Yeah. Where'd you hear it? Drug information. Okay. All right, so this is specifically used for detecting and staging chronic kidney disease. Now, when you look at most of your like package inserts or drug dosing or what we talked about, even VTE, did I tell you the GFR? We dose drugs by GFR. Didn't, right? We have another equation that sort of does a similar thing, but it is different. Creatinine clearance, right? So we're much more familiar from a pharmacy standpoint with the creatinine clearance equations and the concept of creatinine clearance. So the creatinine clearance does a similar but subtly different thing. So while the glomerular filtration rate is an estimate of kidney function, your creatinine clearance is an estimate of the glomerular filtration rate, which is an estimate of kidney function. So this is an estimate of your kidney function. So it has some limitations. Okay? The creatinine clearance may overestimate the GFR, and the reason for that is because we can look at physiologically where creatinine is cleared. Right? Creatinine is something that your body produces and eliminates on a continual basis, and you end up having a level in your body that's steady state, right? Do you know where creatinine comes from? It comes from your muscles, right? It's eliminated by your kidney. So creatinine comes from your muscles, and then it's lost actually in two places. So the creatinine is filtered at the glomerulus, which would be like your glomerular filtration component, but it's also lost in active tubular secretion. So you actually lose creatinine at two places. So this sort of makes sense. You overestimate how well the kidneys do because you clear creatinine, not just looking at GFR, which is our proxy for kidney function or a marker for kidney function, but it gets secreted elsewhere also. Does that make sense? Okay. How we figure out creatinine clearance is the most common way is the Koproff-Gault equation, although there are other equations. Koproff-Gault is the most common one. And we use the creatinine clearance equation to dose medications. So as you've been going through D&Ds, you've seen, oh, give this dose, have a creatinine clearance less than what VTE was like 30 for everything, right? You could give a different dose of the medication. So as a pharmacist, when you're focusing medications, you're probably going to use Koproff-Gault equation a lot more. If you're a nephrologist and you are staging kidney disease, you're probably going to be thinking MDRD in that setting. Okay? And there's the equation there. I do expect you guys to know how to use this and to know it. So any questions so far from the last couple slides? Okay, so some of the limitations to these equations are based off of that creatinine being not really the most reliable of numbers. So creatinine comes from your muscles, you're right, and muscles are affected by gender. Males and females have a different creatinine clearance equation. Actually, you know what? There's an adjustment for the females. So the Cockcroft-Gold equation in the box that I have on your handout has creatinine clearance equals 140 minus age times ideal body weight, etc. That's for males. For females, you multiply by 0.85. Add that into the handout. I'm going to add it in also. So you multiply by 0.85. The reason for that is that females generally have less muscle mass than males, so they produce less creatinine. As you get older, you're going to have less lean muscle mass. You learn in geriatrics, I think. Well, fat goes up, water goes down, muscle mass goes down as you age. Concomitant medications, diet. So what we often do in patients that have a low serum creatinine, like geriatric patients, we often round up to avoid overestimating creatinine clearance. So I have two examples of the Cockcroft-Gault equation here. Looks like a 85-year-old, 48-kilogram patient on each side, and on one of them, I left them with a serum creatinine of 0.4 on the left side, and on the right side, I rounded up the serum creatinine to 1, because maybe an 85-year-old, 48-kilogram patient doesn't have a whole lot of muscle mass. So this creatinine is low, not because their kidneys are awesome, but because they don't have a lot of creatinine being produced, stored in their muscles. So I want you guys, real quick, do the calculation for me. Perhaps maybe like this side of the room can do the 0.4 version, and this side of the room can do the version using a 1, rounded up to 1. And just tell me what we get. Take a second. Did anyone get in on this side? 0.4 we get. What did you get? 91.7. That's mLs per minute. 91 mLs per minute. And what about on this side? I'm rounding up. 37. 36, 37, something like that. So you can see drastically, if you decide to use this, the lab drawn level or round up 90 versus 30-something mL per minute. We haven't established the context or the breakpoints of different levels of dysfunction, but you know from D&Ds that 90 versus 30 should be a big difference, right? A lot of drugs get changed dose at like 30 mLs. So you couldn't misdose a medication if you don't do this properly. Some other notes for the creatinine clearance equation and the MDRD equation and most of the other creatinine clearance equations. They're not meant for acute kidney injury, so this is meant for steady state creatinine levels. The patient has to have stable kidney function in order for these equations to be validated. They were validated in like a healthy population of middle-aged people. Cockcroft-Gault is from a study in like the mid-80s. Healthy people. So in patients that have kidney function that's moving, that's getting better or getting worse, there is no equation. You kind of have to just use your judgment on what you think is happening clinically. So there's other equations for other populations, for children, obese patients, patients that have very high GFRs, you can do something a little different. But the most common one is Cockcroft-Gault equation. That's probably all you'll have to know for your boards. Questions?
Sorry, just to confirm, so if you have an elderly patient
Yes.
and their 0.4 is the serum creatinine, I do round it up to 1?
Typically, you will round, if you have an elderly patient and the creatinine is below 1, you will often round up to 1, yes.
Elderly is like past 60?
Elderly, you'd be wrong to say like on your 65th birthday, something happens and like your creatinine drops